These are going to be board-style questions about the style and the depth that we believe that board questions in the renal boards would be when they come up. So we'll just launch right into it. First case, a 35-year-old man with bipolar disorder maintained on lithium for 10 years is referred for chronic polyuria and polydipsia. He's been voiding once an hour, usually not very pleasant. Sodium is 144, serum osmolality 292, 5 liters of urine per day, and his urine sodium and osmolality are as shown. And so the question is, all of the following might be appropriate in the management of this patient except. So one of these is wrong. Thiazides, dietary salt reduction, stopping lithium, fluid restriction, and amiloride. So if you could use your audience response, click this to pick a choice, and we'll see how many people are back from lunch and awake. And since these are long sessions, this is a good time to fill up on some coffee too, if you haven't already. Okay, excellent. So most of you picked the correct answer, D, which is fluid restriction. You can approach this case from probably two different viewpoints. One is the differential hypernatremia. The other way is to think of it in terms of the differential for polyuria, which is what this patient had. Polyuria being defined as a urine output of more than 3 liters per day. There are basically two causes of polyuria, an osmotic diuresis or water diuresis. And the distinction between them rests on whether the amount of osmoles that are being excreted per day is normal, which is usually less than 1,000 on a normal diet, or abnormal, meaning greater than 1,000. An abnormal osmolar excretion rate suggests that there are extra osmoles in the urine and that's what's driving the diuresis. So a patient who's getting a lot of IV saline, a patient with a hyperglycemic condition, a patient recovering from acute renal failure, or someone that you happen to be giving mannitol. Just to remind you, osmolar excretion rate is calculated as the urine output times the urine osmolality. If it's less than 1,000, then all that extra volume must be water. So why would you have extra water in the urine? Well, two possibilities. Either you're drinking a lot, psychogenic polydipsia, in which case the serum sodium should actually be low, or diabetes insipidus, a spontaneous inability to concentrate urine, in which case the serum sodium should be high. So this patient obviously had diabetes insipidus. The cause of the diabetes insipidus, based on the clinical setting, was most likely nephrogenic DI from lithium, which is fairly common. So we usually treat that by stopping the lithium if we can. Amiloride seems to help because it blocks lithium entry into collecting duct cells by blocking ENaC. Dietary salt restriction and thiazide diuretics are often used in patients with nephrogenic DI. They don't treat the underlying cause, but what they do is to help to reduce urine output, which is one of the more troublesome symptoms of diabetes insipidus. The one thing you don't want to do in these patients is restrict fluids. So the only thing that keeps them from having a serum sodium that goes up to 150 and 160 and so on is thirst. And so even though their kidneys can't concentrate, by driving thirst, the hyponatremia is corrected by drinking water. If you fluid restrict them, it's extremely dangerous. Okay, so moving on to case 2. A 55-year-old man with colonic carcinoma undergoes resection of his tumor and a diverting colostomy. Post-op, he has prolonged ileus, needs to be on IV TPN. 4 days later, consult is called for hypernatremia, and on exam, the patient is clinically euvolemic but has a serum sodium of 151. Rest of the electrolytes is shown, urine osm 480, sodium 30, volume 3.7 liters. And the question is, which is the most likely cause of his hyponatremia? Is it central DI, nephrogenic DI, osmotic diarrhea, osmotic diuresis, or excess IV saline? Okay, good. So again, the audience is always right, and the majority of you chose the correct answer, which is that this is an osmotic diuresis. So if we were to approach this from the point of view of polyuria, more than 3 liters per day, the osmolar excretion rate in this case is 3.7 liters times by the urine osmolality of 480. And that turns out to be, let's see, almost 2,000 milliosms per day. So a very high osmolar excretion rate. So this is probably an osmotic diuresis. Why does this patient have an osmotic diuresis? Notice that this patient's BUN is very high. It turns out that patients who get large amounts of protein or amino acids in the TPN generate large amounts of urea from it and can develop a urea-induced osmotic diuresis, and that's the most likely cause in this patient. The other thing that's important to recognize is that when you have an osmotic diuresis, for example, driven by urea, it basically draws free water into the urine. And so you end up losing net amounts of free water. And so an osmotic diuresis is a cause of hypernatremia. So conversely, if you want to look at this from the point of view of hyponatremia, this is how I approach hyponatremia. I start by asking, is the urine osmolality appropriately concentrated or not? If it's appropriately concentrated, meaning it's above 800, then the causes of the hyponatremia are extrarenal, meaning insensible water loss, GI water loss, meaning an osmotic diarrhea, or excessive sodium intake without water. If the urine osm is not maximally concentrated, it suggests renal water loss. And the two causes of that are diabetes insipidus and an osmotic diuresis. And in this case, the cause was an osmotic diuresis from urea. A 17-year-old woman who is otherwise fit and well and on no meds presents with a history of polyuria since early childhood. And her serum sodium is 141, osmolality 285, urine osmolality of 210, urine volume 4 liters. She undergoes a 4-hour water deprivation test, at which time her serum sodium goes up to 146, osm 298, urine osm of 250. She then gets 10 micrograms of intranasal DDAVP, and her sodium is 143. 1 hour later, our urine osmolality 585. So the question is, which of the following statements could be true? She's entirely normal, since baseline serum sodium is normal. Water deprivation test is non-diagnostic. She has central DI, she has nephrogenic DI, or she has an osmotic diuresis with washout of her medullary concentrating gradient. It's a little complicated question, so you might want to read those answers carefully so you don't choose the wrong one. Okay, good. So most of you chose central DI, which is in fact correct. You guys are really on the ball, especially since you had such a long morning session. I'm very impressed. This particular patient was not in fact actually hypernatremic when she presented, but she did have polyuria, and that's a frequent problem that we have. For example, if you have diabetes insipidus, but you drink enough water, you can keep your serum sodium close to or in the normal range. So in order to elicit what the problem is, we usually start with a water deprivation test if they're not already hyponatremic. And in this patient, when you did a water deprivation test, she indeed became hyponatremic. How hyponatremic do you have to be? We expect to see the plasma osmolality exceed 295 because that's the level at which ADH release is maximally stimulated. Okay, so if your plasma osmolality gets above 295 and you still can't exceed 800 in your urine osmolality, then you have a concentrating problem. Usually diabetes insipidus. So this is an adequate water deprivation test because water was deprived until the plasma osmolality got above 295. Once this happens, you want to ask, can you correct the urine osmolality by giving DDAVP? Now, DDAVP is not going to correct it initially all the way back to normal. The usual threshold there are several possible thresholds, but one that's easy to apply is that the urine osmolality should go up by more than 50%. In this patient, DDAVP doubled the urine osmolality, so that counts as a good response. And so that would indicate that this patient didn't have maximal circulating levels of ADH and that the renal tubule response was appropriate, hence central DI. So C is correct. Okay, next case. An 87-year-old woman tripped in her bedroom at home and was unable to get up. She was found by her neighbor 3 days later and brought into the emergency room, at which time she had a broken left hip, was severely dehydrated, and making small volumes of very concentrated urine. And her serum sodium was 157, sodium less than 5, urine osmolality of 850. So the question is, which of these statements is true? Her hyponatremia is due to osmotic diuresis. She likely has underlying diabetes insipidus. Treatment carries a potential risk of cerebral edema. NSAID would be helpful. Her intracellular fluid volume is increased. Okay, good. So C is indeed the correct answer. So this is a patient with hypernatremia who has a urine osmolality of greater than 850. So she's concentrating her urine perfectly fine. So she doesn't have diabetes insipidus. She doesn't have an osmotic diuresis. She has extrarenal water loss. Where's the extrarenal water loss? It's pretty obvious here that she had insensible water losses while she was lying at home and not being found. So A, B, and B are incorrect. D is also incorrect. NSAIDs are used in the treatment of nephrogenic DI. She doesn't have that. And E is obviously incorrect. She has volume depletion. And in fact, in the setting of hypernatremia, intracellular volume is disproportionately reduced. So C is the only one that's not false. And in fact, when we treat hypernatremia by bringing down the extracellular fluid osmolality, if done too rapidly, there's the potential risk for water to osmose from the extracellular to the intracellular fluid and cause cerebral edema. This is a particular problem in children, much less common in adults, but is a theoretical risk. A 45-year-old female underwent transsphenoidal resection of a pituitary adenoma 1 week ago. Immediately post-op, she developed severe polyuria and started on DDAVP. She returns with change in mental status, has a seizure in the emergency room, and is found to have a serum sodium of 114. And so the question is, which of the following statements is true? Her post-op condition was almost certainly misdiagnosed, and she should never have been treated with DDAVP. She currently has DI. Her hyponatremia now is most likely due to central hypothyroidism. Her hyponatremia is primarily due to psychogenic polydipsia, or she is at risk of developing diabetes insipidus. Okay, a little spread of opinion here. So the answer turns out to be E, and I'll tell you why. This is what happens after patients get pituitary surgery. So immediately after surgery, there is frequently an episode where secretion of vasopressin by the posterior pituitary is arrested transiently. And this usually lasts from 1 to 5 days. And that's shown here. So there's 1 to 5 days of hypernatremia and polyuria. And it's so frequent and expected that surgeons routinely treat these patients for the first few days with DDAVP. So the treatment of DDAVP initially is perfectly appropriate. In about 40% of cases, this resolves after 4 to 5 days, and the patient is completely normal. In the minority of patients, this is followed by a period of retrograde degeneration of the secretory neurons, and as those neurons degenerate, the intracellular stores of vasopressin that are in there get released into the circulation. At the end of the first week, you get the opposite, where there's too much vasopressin released and an episode of SIADH. If your patient is getting already DDAVP and no one's monitoring their sodium levels, then you really have a significant risk of developing hyponatremia. So this has to be followed very, very carefully. And then in a small minority of cases, once this degeneration has ceased, the remaining neurons that are present are either there are none, or there are so few that remain that there's not enough to release a vasopressin normally in response to hyponatremia. And so those patients have permanent central diabetes insipidus. Obviously, that has to be a minority of patients because the surgeons try not to cause permanent damage to the posterior pituitary. So often only about 1% of patients develop permanent central DI, but it is certainly something that the patient is at risk of. So E is correct, that this patient is at risk of developing diabetes insipidus, but what the patient in this case has right now is transient excessive ADH release. So A through D are all incorrect. 64-year-old woman with coronary artery disease and ischemic cardiomyopathy, EF of 15%, is admitted with pulmonary edema. She's on these cardiac meds. Blood pressure is a little on the low side. Pulse rate 85, JVP 9 centimeters, lungs with inspiratory crackles, S3 callop, cool clammy extremities, and 4+ edema. And her serum sodium is 128, and BUN creatinine 46 and 1.2, serum osmolality 264. And 6 hours after the last diuretic dose, she gets urine electrolytes done, which show that her urine sodium is 15, urine chloride is less than 5, and urine osmolality is 220. And so the question is, all of the following might be appropriate in the management of this patient, except IV saline, normal saline, restriction of free water intake, dietary sodium restriction, dobutamine, or acetazolamide. Okay, good. So the majority of you chose A. A few of you chose acetazolamide. I'll tell you why I think acetazolamide is okay. So the way that I approach a patient with hyponatremia, the first question to ask is the patient truly hypoosmolar? So you need to know the plasma osmolality. If it's normal, that would suggest pseudo-hyponatremia. If it's high, it might suggest the presence of additional osmoles like hyperglycemia or mannitol. If the patient is truly hypoosmolar, which this patient is, then this is the differential diagnosis. The key here is that urine osmolality and AD is low, and ADH levels are low in only one of these conditions, which is psychogenic polydipsia. And in all of these other conditions, urine osmolality is above 100. In other words, the patient's urine is not maximally dilute. And in this particular patient, the most likely cause is, of course, cardiac failure. This patient had clinical evidence of both forward output failure and also congestive symptoms. And in that setting, they have what's called effective circulating volume depletion. The kidney perceives as if the patient is volume depleted. The kidney retains sodium and chloride. That's why urine sodium and chloride are low. And in severe cases of effective circulating volume depletion, as we discussed earlier this morning, there is also volume-mediated release of ADH, which causes hyponatremia, and that's what happened in this patient. So in terms of the treatment, IV saline would not help in this case. Let's go back to the answers. Because the problem is not actual volume depletion, it's effective circulating volume depletion. And in fact, in a patient like this, giving saline would not only not increase the cardiac output and renal perfusion, but one might argue it would cause worsening myocardial stretch and potentially reduce cardiac output. Restriction of free water intake is appropriate in almost all patients with chronic hyponatremia and will help to reduce serum sodium by just reducing the amount of water getting into the body. In this particular patient with CHF, dietary sodium restriction would help. Dobutamine or some sort of inotro might help in this patient by, again, increasing cardiac output and helping to perfuse the kidney. Acetazolamide does not address the hyponatremia per se, but it would act as a diuretic and help to further diurese this patient. And it has the advantage that it would help to correct the metabolic alkalosis that this patient had due to presumably excessive diuresis with loop diuretics. So we often use acetazolamide in that setting in patients with congestive heart failure. So E is okay, but A is clearly the answer that's wrong. A 45-year-old male smoker presents with confusion and drowsiness. He's on bronchodilators and steroid inhalers. He clinically seems to be euvolemic. Chest X-ray shows emphysematous changes, and his serum sodium is 116, serum osmolality 256, urine sodium 96, urine osmolality 670. And the question is, what's the appropriate next step in the management of this patient? Is it thyroid radioiodine scan, CT scan of the chest, thiazide diuretic, haloperidol, or normal saline? Okay, good. So most of you picked B, which is a CT scan of the chest. So this is a patient who has hypoosmolar hyponatremia, is euvolemic, and has an inappropriately concentrated urine. So SIADH is high on the differential. We almost always have to check for hypothyroidism, which can mimic this, but the appropriate test for that is obviously a TSH, not a radioiodine scan. That's why A is wrong. Usually in these patients with euvolemic hyponatremia, we also check the cortisol levels for Addison's, because not all patients with Addison's appear hypovolemic, and that can be a diagnosis can be missed if we don't look for it. But this patient most likely has SIADH. In the setting of being a chronic smoker, we certainly have to consider strongly the possibility of small cell carcinoma of the lung as the cause, and so hence the CT scan is an obvious next diagnostic step. Thiazides are not useful in the treatment of hyponatremia. In fact, they worsen it. Haloperidol is perhaps a reasonable treatment for psychogenic polydipsia, but this patient clearly doesn't have it. And then some of you thought that normal saline might be okay. And I'll explain to you why, in fact, that's not the case. And this is an important point, though it's a difficult one to grasp. So and this is the reason I put it in, is because there is a common misconception that if a patient has a serum sodium 116 and they get in normal saline, 0.9% sodium chloride, which has a sodium concentration of 154, that this should elevate your serum sodium. But to think that would miss a very important point, which is that at the same time that you're giving the saline, they're putting out urine. And because patients with SIADH are euvolemic, they'll probably put out a liter of urine for every liter of saline you put in. So the key to understanding what happens to serum sodium is what's the composition of the urine compared to what's going in. And this particular patient, the urine was very concentrated and had a sodium of 96 and a potassium of 87. Now, you could say, well, the urine osmolality is very, very high. We don't usually go by just the urine osmolality, and that's because the urine osmolality is made up in part from urea, and urea, as you know, is an ineffective osmol. So what we're really interested in is the components of urine osmolality that's composed from electrolytes, sodium and potassium, not just sodium, and chloride and other anions. And so the effective osmols are really 2 times the sodium plus potassium. And here, the sodium plus potassium is about 170, 180, and 2 times that is 360. Whereas the osmolality of normal saline is 2 times 154, which is 308. So in this patient, the urine tonicity would actually be even higher than that of isotonic saline. And so the prediction is that if you give this patient isotonic saline, their serum sodium, far from being increased, would actually continue to fall further. So you would harm this patient by giving normal saline. Now, for those of you who are brought up on the concept of electrolyte-free water clearance, another way of saying this is that electrolyte-free water clearance is negative. So in a patient like this, you don't want to give normal saline. If you have to bring up the sodium rapidly, you need something a lot more concentrated than isotonic saline, like hypertonic saline. And that's the reason why this is wrong. So in SIADH, isotonic saline is appropriate only if urine sodium plus urine potassium is less than 150, or 2 times urine sodium plus potassium is less than 300. An 18-year-old woman with schizophrenia maintained on haloperidol presents with a generalized seizure. Her serum sodium is 120, osmos 252, urine osmolality of 90. Which of the following statements are true? The serum lipid and total protein must be measured to exclude pseudo-hyponatremia. Her condition has been caused by haloperidol, which should be discontinued. Correction of the hyponatremia may be complicated by cerebral edema. Serum sodium can be corrected at 1 to 2 milliequivalents per liter per hour. And fluid restriction will not correct hyponatremia. So only one of these is actually true. Okay. A little bit of dispute about this. D is in fact the correct answer. So here's a hyponatremic patient whose urine osm is less than 100. So they're maximally diluting the urine. So there has to be another reason other than the kidneys why they're hyponatremic. And the only possibility is that they're drinking water faster than it can be excreted. So this is a patient with psychogenic polydipsia, and the appropriate treatment is fluid restriction. This is not pseudo-hyponatremia. Serum osmolality is low. If the serum osmolality were normal, you would suspect pseudo-hyponatremia. This condition is not caused most likely by haloperidol. Haloperidol and other antipsychotic drugs are associated with SIADH, but this is not SIADH. C is also incorrect. The hyponatremia itself, when acute, can be complicated by cerebral edema, but here it says the correction of hyponatremia. Correction of hyponatremia causes a different problem, which is osmotic demyelination syndrome, or some people know it as central and extrapontine myelinolysis. So C is incorrect. D is in fact correct. So most patients with psychogenic polydipsia have acute hyponatremia. It can be essentially assumed that this is acute, and therefore their hyponatremia can be corrected quite rapidly. And in fact, you would like to correct it rapidly in this patient because she is also symptomatic. She has a generalized seizure. And so you can go up to 1 to 2 milliequivalents per liter per hour quite safely. A 19-year-old male who recently returned from trekking the Himalayas had watery diarrhea for 1 week. He looks tired, mucous membranes are dry, he's orthostatic by pulse and blood pressure, and his serum sodium is 128, potassium 2.8, bicarb 18, BUN creatinine 48 and 1.1, urine sodium less than 5, urine osmolality 350. Which of the following would be the most appropriate? Hypertonic saline, conivaptan, normal saline and hydrocortisone, normal saline and furosemide, or normal saline and potassium chloride. Okay, good. So almost all of you chose E, which is the correct answer. So obviously this patient is hyponatremic due to GI salt and water loss and the consequent development of hypovolemia. In that setting, there's volume-induced ADH release, which causes the urine to become excessively concentrated. If you treat this patient with isotonic saline, it does two things. The first thing it does is it obviously restores the extracellular fluid volume, but the second thing it does is it shuts off ADH. So as you give normal saline to this patient, you will see the urine osm fall, and by the time their volume replete, close to volume replete, the urine osmolality should get down below 100, and they will have a water diuresis and spontaneously correct their serum sodium. So you don't need to give these patients hypertonic saline. You don't need to give them an aquaretic. In fact, doing so would cause that serum sodium to correct too rapidly. And there's no real indication for hydrocortisone or furosemide. So you really just need the normal saline and obviously repletion of potassium in this patient. An 18-year-old female colleague